Hello, everyone, to our panel on Riding the Storm, the untold story of Africa's response to the COVID-19 pandemic. We published the book that the panel is supposed to be based on, and I fought against that title for so long. But I guess we were telling the story, so it was no longer Untold. My name is Dr. Eghosa Imasuen. I'm a former medical doctor. I write novels and I publish books now. Very weird career choices all my life. I hope to sell fries one day. I think I will enjoy that more. So yes, so like she said, this panel will examine the history of the pandemic from our point of view. And I'll be joined by two experts who worked and experienced what we saw in West Africa from this point of view over here. It will also, a small anecdote on my part, I think at the beginning of the pandemic, when the lockdown was going to happen in March, we were already getting feelers from the Medical and Dental Council of Nigeria that if things went as bad as was projected for the continent, that those of us who had not renewed our licenses were going to be given free new medical licenses. And there would be no excuse for us to not do anything, but we were never called. Why? The story of the book came about because of an interest that we, the publisher, coincided with the writers, the writers wished to also tell this story, specifically about a group of 4 people who held Zoom meetings from the UK, Egypt, Addis Ababa, and Nairobi, I believe. And those 4-person Zoom calls soon grew up to encompass 20 people, most of them policymakers from around the continent. And the little miracles that we saw happen versus the big miracles, even despite the bad things that we knew were happening, the difficulties with inconsistent spreading of daily cash payments, the difficulties post-pandemic with the economy, that it was never as bad as people feared it would be. There were statements like there will be bodies on the streets, etc., etc. So that's what the book is about. How did that happen? Was it by luck? Was it by chance? So with me today is Professor Thumbi Mwangi.
Yes, Mwangi.
Yes. He's an infectious disease epidemiologist. Graduate of veterinary medicine and surgery, 2005, Nairobi, with a PhD from Edinburgh, 2012. He's the chair of your Kenyan National Technical Committee on COVID-19 modeling. He was the chair. And he's a member of the Technical Review Committee of the African Union's Africa Risk Capacity, specifically the Epidemics and Outbreaks Program. So who better to join us today to give a point of view of what happened? Why didn't it go as bad as was feared? Then also, there's Mark, who have apologized about the surname. Laichena. Mm-hmm. He's the Chief Strategy Officer of SHOFCO. He's had a storied career in non-governmental work. And is a graduate, I think you studied in the US, and works with Kennedy Odede's foundation in the Kibera slums. He was quite instrumental in a daily cash transfer program that actually surpassed what the government said they were doing. It was much more effective. Welcome, gentlemen.
Thank you.
Yes.
Thank you.
So I think we'll just jump right in. So to Prof. Thumbi, at the start of the pandemic, what did Kenyan models predict? And how did the reality eventually compare? So for example, how did you walk around informal centers? I know we were having a talk about it. Did it ever get to the stage where your projection and the decision to forego mass testing? I just want the intersection, how epidemiology works. Just educate us.
Thank you. So the word you mentioned, epidemiology, is about the study of disease patterns, how disease spread in communities. And you can simplify a very complex world of disease spread in the mathematics that you learned in high school. If you capture the main characteristics of whatever is spreading, not every detail, but the main characteristics, so as you get the full picture. And that means you can sort of make a prediction what could happen if certain conditions are met. So that's what we were using to have a view of, or have like peep into the future. And we were using initially data that came from, say, Italy or China, because we had not had cases here. And what you're observing on that side was a very high case fatality rate. Whatever, like if you are infected, what's your likelihood of dying?
Yes.
It's very high. So then if you take that data and bring it to Kenya, before we get the first cases, we got a really bad picture that at the beginning, we were estimating we'd lose more than 100,000 people.
And this was compared with the infectivity rate, the arrow not number?
Yes. And that 100,000 people that would die from COVID sort of changed as soon as we started getting our own data. Because for models, they are as good as the data that you give them. So once we understood that old people are the ones that are likely to end up in death and the young people are less affected, that completely changed. Just to give you some reason for that, if you think about the median age of, say, somebody who lives in Italy, it's about 45 years. Here in Kenya, we are about 20 years. Our Ugandan friends are actually 19 years.
Nigeria, 17 and a half, 19.
There you go. So because of the very young generation, and the virus was not affecting the young generation as much, then we had to revise our estimates of what would be the eventual number of deaths, coming down. At some point, we settled at about 25,000. Eventually, we saw 5,000 or 6,000 that died from COVID-19.
But there was this other idea that the COVID vector was people, which means that younger people being active would spread disease more. I think we'll come to that when we speak about vaccination strategies. So let us go into when lockdown became imminent. Everybody knows where they were, but I'm going to ask Mark specifically where SHOFCO was, because in a study you published, your organization published a few years later, your data showed that 72% of slum residents had only 2 days savings. 2 days savings. How did the organization prioritize urgent needs, water, food, sanitation, cash transfers under lockdown? And how did cash transfers come into play there? And how were you able to do it better? Because I think Human Rights Watch also queried the government's own version of the cash transfers. How were you able to do it better than the government? And also, let's start there, because we know where this is going. Yes.
Yeah. So I mean, as you note, the lockdown was brutal for people who are daily wage laborers. I mean, and all of us who are in Nairobi, we saw it, whether that's people who wash clothes or other things, and suddenly just didn't have that daily income. And so that meant Kennedy, my boss at SHOFCO, and others actually were pushing quite hard to make sure the lockdown was as lenient as possible, seeing that the economy had to go alongside with healthcare. But I think really what actually SHOFCO saw was, because we were already doing work providing clean water, supporting on healthcare, running clinics. And what we actually saw when the lockdown happened was that SHOFCO was still there, because SHOFCO was run by people mostly from the communities. But a lot of other organizations, sort of their risk policies started to say, oh, well, there's COVID, so our staff can't come to work today. And actually our country director, maybe they need to fly back to Europe, and sort of these types of things. And so it wasn't so much that SHOFCO stepped up, but actually that others stepped back. And we saw that challenge. So on the cash transfer side, I, at the time, was working for Give Directly, an American nonprofit that had done cash transfer more like business grants, big grants out in Western Kenya, very much, running our own operation. And I think for me, it was a bit of a wake-up call as the most senior African and Kenyan in this foreign non-profit, which similarly to others had thought a bit like, okay, well, COVID means now we pause our operations for a while, and then let's wait till things are safe, and then we can start again. And I was thinking, okay, well, in Europe, they're talking about money to give to people as stimulus. Okay, so what can we do here? And the challenge was in COVID, though, how do you go into communities? How do you go door to door? How do you manage the health and safety? And so then for me at Give Directly, I was thinking, well, how on earth can we possibly get to know what's happening in communities? And so that's what led me to SHOFCO. And so for SHOFCO then realizing, well, actually, SHOFCO already worked with young people. And so it was quite easy to say, well, actually, here are 30,000, 50,000, 100,000, young people that we're already working with, and to be able to partner, then to be able to do cash transfers efficiently. So I can share more, but
thank you
for time, I'll give you that.
Yeah, no, thank you for that, because I think it also segues perfectly into the start of lockdown implementation policy. So in Nigeria, the first 7 COVID deaths were not caused by COVID. It was by police enforcing the lockdown. It was funny then, even though it was tragic, because I remember it became a Nigerian typical really dark joke that the Nigerian, we killed more people, Nigerian authorities killed more people enforcing the lockdown than COVID itself in the beginning. I think in the north, there was, 3 or 4 boys. Then I think in Warri, one of the Niger Delta areas, a gentleman with pregnant wife was racing to go and get fuel for his generator because the power was out. And he ran into a checkpoint and tried to bypass it and turned over his car and died. That was the first person. The first COVID death in Nigeria was a car accident during lockdown. So it was, but then it now comes back to policy. From your perspective, how did the collaboration occur internationally? How did you see the doctor speaking truth in a certain way to power? Telling them that, no, you're wishful thinking, no, we don't know, you need to shut down. And how does that work eventually with the idea that if you're correct and the shutdown works, people will tell you that it was unnecessary? How does that work? How do you manage that as a healthcare, somebody in public health specifically? But from there, we'll talk about, I'll follow up with the idea of public policy from your perspective and the connection, the international connection that African countries had to make amongst themselves, yes. But first of all, speaking truth, telling them that being the canary in the coal mine as a way of speaking.
Thank you. I think you raise a good point. So I come from the academic world. I'm within a university. That means I can collaborate with the Ministry of Health, but they really can't. They're not my direct bosses, so I can tell them the truth. And I think that's the arrangement that Kenya had, that we had COVID-19 projections coming from higher institutions of learning. And then we had opportunities to sit with the minister and the directors of health and talk about what we are seeing from our own analysis. I think that separation of who is acting on policy and who is informing policy is really critical. Otherwise, it becomes very difficult to tell your boss that I think you're wrong.
Yeah, that's good. And so based on that, what was, from your own perspective, when the decisions were eventually made, when there was this acquiescence amongst the continent's leadership to lock down, what did you see happening? What just a personal perspective, yes.
So I think if you remember, the lockdowns that happened, like in Kenya, are not the same kind of lockdowns that you found, say, in Europe and partly what we had was curfews, like in the evening stop. It was very deliberate at the time because we couldn't fully lock down this place because of livelihoods. So we found what are the most dangerous contacts, and Kenyans love to party, and Going to party was one of the things that we feared. Like these events where people really are very close to each other, they have their guards down, congregate, and you can have the virus spreading, while still maintaining a level of activity during the day to allow for economic things to happen. So that was the reasoning for. And if you remember, very early on, there was also people are sort of being forced into quarantine areas, and that was very difficult because once you have the first cases, you want to minimize the spread. So you want to identify, do a contact trace, find the person who is infected, and have them isolated. So when they didn't have isolation places, so they created those isolation places. When people went there, they started escaping over the wall. So
that means they were not really ill.
Well, exactly.
They were strong enough to climb a fence.
Exactly. Some of them were young people who had the virus, but they really were not coming down with it. So they could actually scale the wall and run off. Antigen
positive, yes. They become like a carrier themselves and can get older people sick. Yeah. So from your perspective, working adjacent to the economics of it, to the livelihood part of it, how did you see how the decisions were made? And going forward, what were you noticing about the international environment? I'm speaking specifically about scarcity nationalism. The idea that everybody needed to buy everything as quickly as possible. When they said lockdown could occur but could be ameliorated by personal protective equipment. How did, from your point of view, in terms of intervening with the poorest and with the most needy, what did you notice? What did you see?
Yeah. Is this working? Oh. I'll try this one. So what did we see? I mean, I think that, we all saw how everyone rushed out to go and buy everything and stock up. But as you know, if you've only got a day or two worth of savings, then how can you go and what can you buy if you're a security guard and that's what you need? And so that's why when we started doing cash transfers, we were thinking, well, what can we provide that would allow someone to go and just get basic needs for for a week, for a couple, we were doing 3,000 shillings monthly, but then the idea being that you can use that to actually stock up a little bit. But because the point being, I mean, if you're sick, how can you even stay home and not go out and infect others if you need to go out and earn each day? I mean, I think the other thing about the lockdown as well that SHOFCO really felt was, I mean, I think as you noted in Nigeria, we had a bit of the same thing. I mean, it's sort of, it was an evening curfew that was better for livelihoods. It started to be a little bit of a kind of the police went back into, okay, it's time to go and chase people and it was quite scary. And there were a lot of similar types of challenges here. And so I think as well, I mean, it eased up, but at the start it felt like an excuse for excess violent enforcement. And the trouble with that violent enforcement is it doesn't happen in rich areas.
No, it doesn't.
It happens in poor areas, and that's what we saw here as well.
Because it's so show of hands. I will ask it in a if you are the one if it's yourself personally, you can also raise up your hand. How many people know somebody close to them who got COVID? Including themselves, we don't mind, but we don't know. But it was weird, wasn't it? We knew. Then there were certain calls we had during that month when testing was late, where we were like, okay, this is the COVID they're talking about, where you kind of knew that you were the one, that you were possibly having it. And the reason why I want to talk about that is also to try and engage from my former profession as a doctor, how I saw the pandemic. So it's something that we've been fearing for decades. There's always been, when is the next big one? And we heard the stories about the 1919, 1920 post-World War I outbreak, which is called the Spanish flu, but actually began in Kansas, in a pig farm. It's just that Spain was the only country that spoke the truth because Spain was neutral and could tell the truth. So Spain was under reported cases, while the other countries were at war and hid their cases. But this idea of the next big thing is about to come, and everybody feared that it was here. And I want your comments on after I'm done. And I think there was also the tendency for, there's a kind of kind pity that anticipates failure. I think kind of low expectations where the fear was that, oh my God, the Africans are all going to die. And while it might come from a good place in many instances, and while the help was actually needed, we weren't frowning at it. But I believe that something had happened 5 years before that actually primed us for success, and many people didn't know when it happened. And that was when Ebola jumped across the continent and landed in West Africa. And what happened with the Ebola outbreak, to give a primer, was in the triangle of the Marble River Union, triangle of countries of Guinea, Sierra Leone, and Liberia, an outbreak occurs in bats. Migratory bats who have been traveling between here and the DRC for ages. This was one that eventually carried Ebola around. Then from there, a man travels to Lagos. And when he lands in Lagos, luckily, doctors are on strike. Luckily, because the vector for Ebola is healthcare workers. Ebola decimates the healthcare profession, but basically the healthcare system is what Ebola co-opts. And if there's anything closest to a zombie illness, Ebola is also a multifactorial illness, which means it's affecting every single system. And guess the worst system it can affect, it also affects the mind. Small microbleeds leading to paranoia, leading to the person actually going out and believing that you are basically zombie apocalypse. But the lessons learned from the Ebola outbreak, from Nigeria's close shave with that crisis, where instead of going to the massive general hospital by the airports, they took Patrick Sawyer across the city, across the lagoon, to the private clinic that the Liberian embassy had to deal with. When he collapsed on the tarmac, the place would have been Ikeja General Hospital, and you do not want to know what could have happened to Lagos. So instead, we had 9 cases that they contact traced, and we locked it down really quickly. But then, after Ebola, the African CDC, African Centers for Disease Control, was founded in 2017 with John Ikengasong. Africa moved to create its own, there was this idea of healthcare, there's this healthcare protocols, that international healthcare protocols or international healthcare, IHR, international health regulations, protocols that African CDC actively had changed just before the pandemic. So I wanted to speak to, just before we put the questions to the audience, I wanted both of you to just talk to me about, I'll give you mine, to talk to me about the general view of how we dodged the bullets, of the right things that we did, and just a general picture of things like Ethiopian Airlines. All the other airlines were getting subsidies from their countries. Ethiopian Airlines went back to Ethiopian government. Ethiopian government said, which money? They said, oh, British Airways got money. Oh, okay, are you British Airways? And the Ethiopian Airlines MD went back, tore out the seats, and converted their entire fleet to air freighters, to cargo planes. And they became the cargo planes for the world during the pandemic. So things like that, say, yes, please.
Yeah. I would research and say, I think the first gift we had was a gift of having lots of young people, and that the virus was not very heavy on the young people. That's one. The second one is basically a gift of time. We, like in Kenya, got our first case on 13th of March. The first case had been announced on 31st of December in China. The first case in Africa or somewhere during Valentine's Day, February 14th. So we had observed for nearly 3 months what was happening. And when the first case came here, the action of the Kenyan government was pretty quick. And that was replicated a lot in the other African countries, that when they got their first cases, they made some actions that reduced the spread of the disease. Then I would say, to your point, we have also been dealing with a lot of other bad diseases. Ebola, we also have some other ones that are endemic, like malaria. So there's a lot of also community engagement about disease, which obviously allowed us to better respond when this.
Which the rest of the world takes for granted, that the skill,
Yeah.
the unknown skill that we've developed, the networking, the public health things that you take for granted. Stay home, wash your hands before you touch that soup. Just the basic things.
I mean, I remember, because I mean, I was doing some work in Goma in the DRC previously, prior to COVID, and as Ebola was coming in North Kivu, and I remember when we first saw it sort of coming down from Buni and so, you know, approaching Goma, and there was almost this terror that if it just somehow got to Goma, then how on earth could it possibly be controlled? But it was, right? You know, the protocols worked, you know, and I so for me, I think when COVID came and I saw, okay, if DRC can do it, right? If Goma can do it, if they can manage hand washing, if they can do that for this scary thing Ebola, then there was this sense of self-belief as well. And I think that, and it makes you think about what are those things that come there. I mean, you know, I think we've got a better community health worker structure than most developed countries, you know. We've got more efforts around pushing things like hand washing and so on. Okay, there's issues of sanitation, but this idea of messaging. And so I think I guess my takeaway was that, yeah, it revealed the strengths, and also it provided pride and confidence in the sense that it was possible, and not something to sort of give up and all, you know, run away from. You know, life will go on. I mean, it sort of feels the same. There's USAID cuts, there's other things, there's whatever, but life will go on. You know, it's like these are challenges. This is really hard work, but these aren't catastrophes. We're not gonna give up in this situation.
Thank you. Okay.
Yeah, well, I would like to add a point that, you know, from a public health point of view, you can say the continent never suffered that much, but
individual tragedies existed.
They do exist, and that's something that we should always recognize.
Always acknowledge, because I think most times when we beat our chest and say there were no bodies on the street, no bodies were found lying on the streets, that people died. Yeah. We lost friends, I lost people. All my classmates are turning 50. I was the youngest, I'm 49, and we lost friends. But on a bigger scale, for some reason, it just didn't do the damage people expected it to do. There have been many theories. I think there are 5 main ones. 1, young population. 2, cross immunity with other coronaviruses. Since our common cold, unlike the adenoviruses elsewhere, some of our common colds are caused by coronavirus relatives. Then there's the idea that there's a racial, but people say no, but the Brazilians are racially close and they wiped them out. So it's just a weird, everybody wants to go. Then of course, then this final one, it was just African competence, which can be scary because it can let you become complacent when you think that you like we say in Nigeria, you overknow. So final question. If you were to contribute a chapter to this book on Ebola, what anecdote, what chapter would you contribute? Prof.
So I think if you read the book, it's a lot about the continental efforts, how we got the COVAX, the vaccines that came to the continent, how they managed to get us testing kits and personal protective equipment. I would say the stories that are not here are the stories lower, you know, like at the country level, because those exist as well. Like,
so which one would you tell? You are not going to go country level, though. Prof. What struck you?
I think it's a story of young people. Yeah. I think you mentioned about in the office, because we did these models and we spent many sleepless nights. I was working with very young people with masters and PhDs in their 20s and early 30s, and they contributed a lot to the decisions that you saw the president making. I think the future is young people, and I would like that story to be part of the chapters.
Thank you so much. And you've already hinted, don't change it. I'm going to tell them, driving at full speed, first day of lockdown, who was in your car and why?
No, I was saying, I remember the first day of lockdown because I had I started lockdown on paternity leave, and my son had gotten a cut, and so I was a scared father driving around and worried that those police who I'd been seeing beating and chasing were gonna come and catch me. But I think for me more broadly as well, like I think that the power of realizing what we could do for ourselves, what communities could do for themselves, was a really powerful one. And I would lean in on more of that. I think there's a story to tell there. I'll give you an example of a SHOFCO, right? I think really before COVID, people thought, oh, SHOFCO is a nice organization in the community. You're helping out in that slum, you can do that. COVID happened, and we were essentially one of the biggest organizations in Kenya's response. And suddenly people started to think, okay, it doesn't have to be these foreign-founded organizations, these foreign-led organizations. Actually, African-led local community solutions can be big. And that's been our journey the last 5 years. It's now saying, look what we did in COVID. Now let's see if we can do that same thing in education.
Yes.
Now let's see if we can do that same thing in livelihoods. Now let's see if we can do that same thing in other areas as well. And so I think that there is something about COVID as a source of, in spite of all of the tragedy, as also I think that the power of realizing what you can do that was learned from that, and all that's going forward to that. And I think we see that with Africa CDC and leaders as well.
Yes.
Where these aren't leaders who we think, poor Africa. These are inspirational leaders who people are writing books about,
yes,
and who
exactly.
are stepping up. We've got Africans at the head of WHO. It's sort of this sense that Africa actually can be looked to as a sense of leadership and ownership rather than as just something that needs help.
Exactly, and I think that segues perfectly into my own preoccupation as a publisher with storytelling. So, to the audience, do you think that we've done a good enough job of communicating why there were no bodies on the street, why the disaster that was expected didn't happen? Do you think you know enough about it, or you just woke up and say, oh, thank God that happened? And you think we can do better? So that's why I did this, and I also wanted to ask the academic writing, sir. Sir, I'm sorry, sir. Just to find out, sir. Academic writing versus normal people's English. What are they quarreling? What is the problem? And so, the serious point is actually, what can we do regarding popular science, popular works for a general audience in basic communication language? Is this something that you think is lacking? The answer is yes. It's lacking in academic writing, and can it be improved upon? The answer is yes. So in between those two yeses, fine, give me an answer. Thank you, sir.
The answer is yes. Yes.
Yeah. Is this something that you find frustrating? That's what I'm trying to say.
Well, yes, but it's also changing. I think we even have some outlets that take the very hard academic work and simplify it, like on the Conversation Africa is an example.
Oh, no.
And there's also an increasing reward system, even in the academic systems, to
accessibility.
Yes, to also make sure that your work is read beyond your small field, and that even the institutions that we work for also recognize that, like your impact to society and how you communicate to society. I think that kind of reward system is making academic writing not as bad as you're describing it.
Yeah, it was really dense. Thank you so much, Mark. Thank you so much, Prof. So, audience, if you have any questions, anything you want to say, comments, any personal experiences during the pandemic, this will be the time to share. Oh, we were really good. Nobody.
We want to forget about the pandemic, which is good.
You scared them with your
You
academic.
scared them with your academic ending. Oh, there's a question. Thank you so much.
Hi, good evening.
Good evening, sir.
Could you just, the story about Ethiopian Airlines is intriguing to me. Could you just elaborate a bit more on that? And are there similar stories that you could share about local decisions that had global impact?
Yeah, so Ethiopian Airlines, it's both anecdotal and actually quite serious. So they were in trouble. All the airlines were in trouble. You knew what was happening with the hotels, airlines. Especially the airlines that were government-backed, which is most of the European airlines that have the government name, that has the country's name. So, most of them, the way they came from the Air Force and became government airlines and the rest. So I remember that there was this massive sum, the numbers skipped me, but several billions were projected to be lost, and they needed subsidies to take off their salaries to make sure that things didn't go bad. So the British government subsidized British Airways and provided a fund for a few other private airlines, France, Air France, Ethiopia went home to go and knock the door in Addis Ababa and asked for, and they were informed, that's the joke, but the reality is that they knew that didn't exist. There was nowhere for that to come from. It didn't exist. And to either let the airline die or let it survive those months that were going into 3, 4, 5 months, the managing director at the time, the name is somewhere in the book, remember I'm the publisher, not the writer, actually had the idea to convert the fleets of 737s and the rest into air freighters with a PH, air freighters. And they uprooted the seats and converted them, and they became the primary transporter of medical equipment, vaccines, and rest around the world from Chinese manufacturers. Because part of the other story is the idea that, so while the Americans were buying up everything, and different African countries were trying to produce lines of connect with Chinese governments, Ramaphosa of the AU, who was president at the time, struck a deal with Xi, where she said 30% of all their production value, guaranteed an African quota, and guaranteed that the African prices would be 30% less than what the Americans were paying, which was cool. But then you produce those things, so how do you now get them over to the continent? Ethiopian Airlines became the world, and they persisted in that role, got, of course, proper cargo planes, and they're basically just taking over the entire global air freighting network, just from the experience with COVID. Now, for medical supplies, you had something like the African Medical Supplies Platform. So what was happening? Different people were doing business. Nigeria, we call them wayorists. Swindlers were attempting to swindle governments that they knew the next connect in China. So the ministers of finance were in trouble. They had the cash, but who to give it to spend and not get swindled? So eventually, at the AU level, connection was made with China, and the different countries participated in designing Fatoumata Ba, who was a managing director of Jumia in Ivory Coast, came up with the idea, and has our own platform called Django, came up with the idea with Strive Masiyiwa to form an African Amazon, but for governments. It had only 55 customers, members of the AU. And they quoted them according to population. So like Nigeria, we had 17% of supplies, because we're 17% of the continent's population. 55% of its loudest population, we agree, but 17%. And the African Medical Supplies Platform was founded. Eventually, they allowed suppliers from inside the continent. So you were sowing whatever, you could go and advertise yourself as a supplier, and you could get buyers from different countries. All the countries needed to do was provide their needs, they would supply, then Ethiopian Air would cargo and drop in the different countries. Of course, we know the clumsiness of real-life, real-world implementation, but those were the kind of things that were built, and they still exist. The African Medical Supply Platform, the pooled procurement strategy, the ability to also produce vaccines, the ability for mRNA sequencing, I think that's in the Republic of Congo. All of those things happened because of the pandemic, and hopefully they will be left there. The Africa CDC becoming the standard that it has built in Addis Ababa and other countries, different countries developing their own CDCs, which is kind of merging academia versus some government power, but while also protecting independence of thought, of thought is so important. So those are the kind of things that have happened. And that is why you should buy. We are selling market, buy the book, and be proud of what we did. Thank you. Oh, there's one more. Oh, I'm in trouble. One more question.
Okay, thank you. I don't know how to frame this question, so I'm just going to speak to a couple of things, then maybe you can respond to it. I get maybe the story about COVID is we had low numbers in Kenya, in Africa, of the number of people who died. But there is certain conversation that I've had in multiple spaces that I exist in that the biggest regret people have with COVID, especially in Kenya, wasn't the disease itself, rather it was the lockdown. People feel or felt that the lives that were stolen, or rather, the experiences, everything that they could have gone through, things that they could have experienced, that was snatched away from them, from the government, from the policies. And I think going into maybe 2019, 2020, people had a lot of faith in the public health system, in the government, in science, in vaccines. But now that the numbers were low, there are people who start to think this disease is one that are serious. People can't think about the fact that maybe Kenya has a greater younger population. That's why maybe the deaths weren't that much. They don't attribute the lockdown processes to, contributing to the low amount of people who, relatively low amount of people who passed away. And then there's this other narrative that I first saw online, and I've now had it again in multiple spaces that exist in, be it people who are learned, people who are college educated, the older generation, people who are in church, that post-COVID, especially for people who took vaccines, they are starting to have this, different symptoms. Maybe they are undergoing specific, what can I call,
Did they specify the type of vaccines that they took?
There is a question of that, but they feel like they develop symptoms, or they started experiencing new diseases, things like diabetes, they started experiencing, diseases maybe that are going to be treated for in a lifelong, for the rest of their lives. And they relate that to, correlation, causation.
Yeah.
So people start to think that maybe this had something to do with, I'm sure, for these people, there is no science to it. And even as someone who maybe has questions about that, there's already a fatigue, about the pros and anti-vaccines, then put into, add the added context of, Bill Gates want to do X, Y, Z,
and Trump is in power and all that jazz.
Yeah. So I think there is, maybe in this space that we exist in right now, people can be able to acknowledge the fact that everything that was done then contributed to the low amount, the small amount of number of people who died. But for let's say for the millennials, in a couple of decades, for the next, God forbid, for the next,
the waves are coming faster. It's probably not 5 years away.
Yeah. So
it's accelerating. So yeah.
For the next one, there's going to be a lot of doubts about the vaccines. Already we have institutionally, people have are very suspicious of government. People don't trust the public health system. What can we do, in terms of, and I know there's everything, so much is happening.
Let him answer, please.
Yeah.
We got it. Yeah. After him, then me.
Okay, so on to your first statement, I agree. I think policy decision making is sometimes very hard, and you have lots of trade-offs to make. Most of the response to COVID was optimizing for health. Minimize the number of people that get to hospital, minimize the number of deaths. Are they, to some extent, affecting livelihoods and affecting experiences of students and affecting people's, social life, and how to have proper trade-off, like when you have some that you can't tell exactly what's going to happen if you don't act. Like when surveillance works, I think you asked that. When it works, then you can almost say you didn't do a good job.
Yeah, you know what I told him at the beginning? I said, what if it works and they tell you that, see, why did you waste our time?
Yeah. So I think that's and that it's an area that you keep improving, to help make that trade-off better. The second component that you're mentioning, I think it's an important conversation to have. From a science point of view, would say that's something that you would pick and do proper studies to look, can you see an actual impact of people who got vaccinated against who did not get vaccinated, and then do evidence synthesis to say, well, this is true or not true. At the moment, I would say it's a good conversation to have. I don't have any good data to say that could be correct or wrong.
Yeah, I think for me to be, yes, okay, I will, sir, please go ahead.
Sorry.
Oh no, I was going to speak to you. Okay, so I think for me, to just be pithy and maybe unfair and impatient, is that, yeah, when people are spoiled. People are spoiled. So 1945, what happens? A war ends, synthetic anti-malarials are invented, the expanded program of immunization kicks off. Penicillin is discovered. The population booms. Those people now in their 70s and 80s, and they've refused to go. So we who were born 30 years later have been looking for jobs and waiting for them to die. The world has changed. The entire level of exchange. People do not know what it is to see a child die of diphtheria. To understand the trade-off that every 100,000 people you treat with an anti-malarial called Fancida, one will die. And yet is Fancida banned? I know this. Quinine is 1 in 15,000. One will die. Is quinine banned? It's a trade-off. And we can pet people and beg them and say, it's for you, it's community. And they can be noisy, but guess what? When a real disaster strikes, most of those assholes are some of the strongest people you need manning the battlements. They become really brave. It's just that it takes so long to convince them, and many times we don't have the patience. People will be people. People are stupid. But life must go on, like Mark said.
Good afternoon. Thank you for this discussion. I want to honor the Bwana who just chimed in with a different perspective. So respectfully, I'm curious of one thing. Does anyone know that in 2015, Bill Gates came to Kenya with an HPV vaccine campaign and left thousands of Kenyan women infertile? And respectfully, I'm curious if anyone knows and or cares that there were 5 African presidents in 2020 who respectfully said no thank you to the predatory WHO, said we'll be trusting our immune system to function as God designed them, and we have our natural plants and such. And the next thing that happened is there were hit pieces put out on those presidents by the Bill and Melinda Gates Foundation, and then they all turned up dead. They were in their 50s, 60s, healthy, no internal conflict in their countries. All that is to say that in this part of the world at least, I would certainly hope for a wider spectrum of critical and, if you will, courageous thought and discernment regarding, shall we say, Western agendas, especially ones that are predicated upon cultivating fear, because we all know through history that once people are in fear on a mass scale, they're very easy to manipulate. And I know these are inconvenient thoughts, especially for some people perhaps on the stage. I have a stepfather who is a Western medical doctor, and he had a very difficult process of disillusionment, seeing how the COVID bamboozle played out. So I've lived like very closely with someone who is like, you know, been through this inconvenient, whatever you want to call it. Bottom line, there's no one who regrets not taking that vaccine, and there's a shit ton of people who do regret it, just like he pointed out, because there's a whole slew of medical problems that they didn't sign up for. And I'm not discounting like polio or other things you mentioned, but the way COVID was put upon us as a bamboozle and as a manipulation begs discernment, especially in the country where just 10 years ago, the same individual with no medical qualifications came here and left women infertile on a large scale.
Exactly my point. Thank you so much, everybody. It was lovely having you guys.